Is now starting. All attendees are in listen-only mode.
Hi, good afternoon, everyone. Today is Friday, May 8th. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We welcome you to the Friday series of DDA updates. Thank you for joining us. We have several presenters today. Bernie Simons, the Deputy Secretary for DDA, Patricia Sasuki, Director of Programs, Rhonda Workman, Director of Federal Programs, and also with us today is Dr. Kenneth Fetter, Epidemic Intelligence Service Officer with the CDC, assigned to Maryland Department of Health for Prevention and Health Administration. Before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. There is one option to listen to the webinar, and that's by computer. There is a handout for the webinar, and you can find it in the handout section of the panel to the right of your screen, and they can also be emailed. We will be recording the webinar and posting it on the DDA website. So now I'd like to introduce Bernie Simons. Good afternoon.
Good afternoon and welcome everybody for being here. Again, this is our series of Friday webinars to update folks and take questions and get a status of where we are within our world of the Developmental Disabilities Administration. And we'll basically follow the same agenda that we've been following with doing our regional updates and talking about Appendix K, which we obviously did the 3 days, Tuesday, Wednesday, and Thursday on Appendix K and operational guidance, a little bit about 1135. And we're fortunate enough again to have Dr. Kenneth Fetter with us, who's from the Center for Disease Control. As you may recall, he's done a few webinars with us on Fridays. And again, we're fortunate enough that we have him here. I hope everybody has been safe, everybody who is supporting families, our direct support professionals who are extremely important to us, as well as our provider agencies, people who are self-directing their services, and our micro boards. And at the end, Dr. Fetter will be taking some questions around his presentation. So again, our highest priority is everybody's health and well-being. I hope everybody had the opportunity to read the resources that we've posted, because at times, sometimes when we get questions, it's like, oh, maybe we weren't clear enough. Maybe the person didn't have the opportunity to find it on our website. Maybe they didn't have time to get to it to read it. But we try and get as much information out there on our website and through our constant contact communication, specifically around the questions on Appendix K and the operational guidance. I mean, it's one thing to get approval from the Center for Medicare and Medicaid Services about saying, you know, you have approval for X, and I'll use a retainer days as an example. But again, what does that mean for an agency, and how do they access retainer days, et cetera? And so as we were fortunate enough this week, again, that we've been making progress on the distribution of our personal protective equipment. And we had our second round of distribution this week that we were able to successfully coordinate for our providers and people who are self-directing in our micro boards. I also want to point out that there's been some issues about providers who have basically said that they cannot go in and get more than what the sign posted is in the grocery store for a certain item. Let's assume it's cleaning supplies, disinfectants, and or whatever to wipe down counters or whatever. And we actually have now got something out. You should have received that communication yesterday versus constant contact with information that when you go to the grocery store, you should have that letter, and you should also have something that says that you're a 501c3 and you're licensed by DDA or whatever the specific guidance was that we put out. I think the more important issue was for you be able to go in and be able to have that discussion with the front end manager, the store manager, or whomever, so that you can get appropriate supplies from that grocery retailer, rather than just going in and saying, you know, I need I have X amount of group homes in my agency. If you're shopping by agency, it might be easier in this time as opposed to by homes. I don't know if that is true or not. It's an individual agency decision to make, but obviously there's variations on how people going out and doing purchasing, and we were just here to try and make sure that we could give you the appropriate documentation that you would be able to purchases larger than what is referenced on the shelf or whatever, like limit 2 or limit 1 or whatever. So we've been working with the Department of Disabilities on some guidance around hospital visitation, because that question has come up multiple times, and something will be going out later on that. You should see that hopefully within a day or so. And then the other issue that came up is, and this has come up because there has been guidance that came out, and so we now have a secretary's order that will be going out immediately that talks about notification of COVID-19 positive determinations for community living participants, people who are in our programs, as well as the direct support professionals. Because, we can't just report on the individuals without the direct support and knowing that they're there to provide supports and services for people. We will be following, as you know, the governor's phase plan for 1, 2, and 3 as we get back, and we will continue to give people updates as we get more information about what that looks like. I know I've had multiple questions from providers about, how are we going to phase back in? What does that look like? In my mind, there are 2 tracks for that. One is, what does it look like for the participants? People have been in their homes or when with their families, and what does that look like as we move from one phase to another, and looking at knowing that we're not going to go back into large group sizes, that we're staying in smaller. What does that look like? And the second piece is, as we move forward with that, what does the workforce look like and the availability of the workforce, and then how many people will be coming back to work if they have either been furloughed or laid off, or, God forbid, have been, having positive testing and not being able to come back to work for a period of time until they recover. And so obviously this is a very complex endeavor that we need to take, and be very thoughtful to ensure that everybody's health and safety is taken into account. You may want to read, if you haven't seen, the Maryland Together, a recovery for a school program. It's about a 50-page document, but it's very comprehensive, and it would probably be useful for us in the world of DD administration to take a look at this. And what I plan on doing is having a conversation next Monday with the DD Coalition, and having some conversations about having some providers and what do they look like. I can tell you that some of my regional directors have basically shared with me that some of the providers within their specific region are starting to develop a plan of how to start moving back towards quote unquote normal when we get there, again, following the governor's guidance on phases 1, 2, and 3. I think we need to start this planning soon. I think we need to take a look at our workforce as well as those implementation strategies, because we're not going to wait until we get to phase 3 and say, okay, tomorrow is a new day and everything's back to normal. I don't know what normal is going to look like, and I don't think anybody does, specifically with some of the items about wearing masks, et cetera, et cetera. So I want to be very mindful of the provider community, people who are self-directing, the micro boards, and where we are as we go through the different stages of getting back to what would be considered quote unquote normal. And I say quote unquote normal because I got an email from one of my previous presentations on these Friday webinars that said that you need to be more careful with saying getting back to normal. I think we all understand that getting back to normal is something that may be totally different, and it might be a new normal than what we've had in the past. I'd like to give you some regional updates and where we are with some of the numbers that we have. I can tell you in the South region, we have 140 participants, individuals that are confirmed positive, 33 negative, 2 pending, and we have had 9 people pass away. In the East region, we have 20 confirmed positive, 16 negative, 1 pending, and no deaths. In the Central region, we have had 55 positives, 59 negatives, 28 are still pending, and we have had 8 deaths. And in the West region, we have had 9 positive confirmed cases, 25 were negative, 1 pending, and 2 deaths. Now, as I said earlier, we're starting to track with looking at the Secretary's order back a couple of slides about looking at individuals and reporting requirements. And again, reporting requirements in there with some time frames, as well as looking at staff, not just people who are in services, which, obviously that's what we're all about, people who are in services, but we need to be mindful and very caring about people who are in our workforce, who are delivering those important services and engagement, and who have relationships with our participants. And so let's talk a little bit about the DSPs who have tested positive. And in the South region, we have had 32 people test positive. In the West region, we have had 14. In the East region, we have had 41. And in the Central region, we have had 87 of staff, direct support professionals test positive. And unfortunately, we have had 3 staff pass away. So we did Appendix K this week. And as you know, and I've mentioned in the past, I was concerned when we were doing the development of the Appendix K that I tasked the Operations and Programs Unit to create operational guidelines that would be available upon approval from CMS. And so we've done that. Those are the webinars that happened this week. So we did receive our approval back a little while ago on April 23rd from the feds. And then we launched everything and we got it out and we got it on our website. And then we started webinars on the 29th with supporting families so that families and individuals would also know, not just our providers, because if you go back and you look at our numbers, we've got about 17,000 people in the waiver, 6,400 live in group homes, some type of provider apartments and or housing, and then the rest of the people are at home. So we wanted to make sure that we included families on this on the front end. And so we did develop also the at a glance and topic specific that were again on our webpage for Appendix K. We do have a dedicated webpage for that. And I'm sure that as we continue to have these conversations and understanding of what the tasks are, what the issues are, what the challenges can be, we'll continue to give updates and work through that. Rhonda, do you want to pick up on slide 8, please?
Yes, Bernie, I'm happy to do that. Thank you. So for this slide, we just wanted to again reinforce that we have a lot of information that is on our dedicated website for Appendix K. And this week we conducted 3 webinars that covered all 11 of our guidance. So on Tuesday, we reviewed information related to our retainer payments, our residential daytime shared service hours, personal supports authorization and exceptions, and also we talked about increased rates for supporting people with the COVID-19 determination. On Wednesday, we shared information about our exceptions to pre-authorization and service requirement exceptions. We also talked about a new service authorization request process that we will be using instead of using the modified service funding plan process. And we also went over and reviewed self-directed service delivery model exceptions. Yesterday, on May 7th, we also talked about our staff training and onboarding flexibility, in addition to services being delivered in alternative settings and out of the state of Maryland, such as supports in hospitals and also in other community settings or family or direct support workers' homes. We also talked about the ability for our community living group home services to be provided in services and homes to exceed their current license capacity. And then also talked about a process to request an authorization to exceed a 1-to-1 or 2-to-1 exception request. If you were not able to join us for our webinars, please note that they are all posted on our dedicated Appendix K webpage for which you can review.
So that's great. Thank you, Rhonda. So again, I think just a reminder that we have everything posted on our dedicated Appendix K webpage. And if you could take a look at the at-a-glance documents and the topic specific, and then the frequently asked questions, the FAQs. And then as we get more questions and need to update the FAQs, they will be updated so that there's a clarity for what is the task at hand in working with Appendix K. Again, I think that the operations and program staff, in my opinion, did a good job from what I reviewed prior to the webinars that were done this week. The 1135, many of you may know, was submitted by Medicaid, state Medicaid, to Center for Medicare and Medicaid Services. That basically was looking at areas that were not the same, obviously, as our Appendix K. And many of you have went in and looked at the application of Appendix K prior to us completing it, and we are grateful for the recommendations that you have given to us. I just want to point out that the 1135 grants us authority to temporarily waive written consent. So we can do things verbally as opposed to always needing something in writing to demonstrate where it is. And I think that that was great on the part of Medicaid to get that in the 1135 waiver, which affected what we do in the world of DDA and our waivers and our targeted case management, as you know, which is a state plan service. So we continue to share information. We will continue to collaborate and ask for information back so that we can make sure that we as the DD administration can continue to keep you updated with any questions that you have, with anything that we need to make clear. And again, I want to thank everybody for their patience and dedication and everything that you've been doing out there. I also want to thank my staff who have worked a lot of hours in the last couple of weeks, either distributing PPE or working on the Appendix K and the guidances, as well as continuing to work on daily operations. So again, I am very grateful to everybody who is here on the phone and those who are not on the phone. And I can say to you also, and I must raise this issue, that in the past, we had a limitation of 500 people when we were doing these webinars. We had a glitch last Tuesday because we have changed the platform. And I can tell you that as of right now, live on our webinar, we have 674 participants. So I think that that's absolutely wonderful that now we can have, more people than just the 500, and then, people are getting frustrated that they couldn't hear it, and, we just have to wait till it's posted, which is what we should be doing in a relatively short period of time to get it on our website. And so again, thank everybody. And now I want to thank Dr. Kenneth Fetter, who's going to do a presentation for us. He is the Epidemic Intelligence Service Officer for the Centers for Disease and Control and Prevention, who's assigned to our department and who has been extremely helpful in working with us in the Developmental Disabilities Administration. So with that, I'll turn it over to Dr. Fetter, and thank you for being here again.
Hi, yes, thank you so much for having me. This is Kenny Fetter, and as was just said, I work over in the Communicable Disease Division at Maryland Department of Health. So thank you so much to everyone who was able to join today. So I'm going to be very brief today and just talk a little bit about what we're hearing about the kinds of challenges you're facing in your programs are, and then talk a little bit about the steps that we're taking to try to better meet your needs as you respond to potential or actual outbreaks of COVID-19 in your homes. So when we say an outbreak, we mean a single case of COVID-19 in a staff member working for a program or a resident of a group home. And as was already discussed, that's what triggers the requirement for reporting to the local health department or the and also to DDA. And so what we are really trying to do is, think about a process that we in the past have put together more for nursing homes and assisted living centers, and trying to better understand the unique needs of your program. And because they are very unique, and the people you are serving have very unique needs, and you face unique challenges and also unique strengths. And so what we're trying to do now is reassess a lot of the strategies that I presented on the previous calls that have been adapted from those other congregate settings to try to meet the kinds of unique challenges and needs that are coming. And I'm going to talk a lot more about this next week, but I'm just going to briefly take 5 minutes to highlight some of the key things that we're hearing and that we're going to try to address through new materials, okay? And then I'm going to take a couple of minutes to answer any questions that you might have. So, the number one thing is the need to put together guidance that meets the unique needs of your programs. And I think what we're going to try to do is put together some checklist tools that are specific to homes for persons with disabilities, and more broadly to programs for persons with disabilities, that can be used as a playbook for responding to outbreaks that's different than our standard playbook, which may have been disseminated in the past, which is primarily focused on other types of group residential living, like long-term care for older adults. I think another major thing that we're hearing is just real challenges communicating with local health departments and with the state health department, and in terms of getting consistent guidance. So we're going to be acting internally to try to streamline communication between us, the local health departments, and programs for people with disabilities. But in the interim, I do want to say that when you have a single person with who's diagnosed with COVID-19, either a resident or a staff person, that constitutes an outbreak in that home. And so you should be assigned by your local health department and by the State Department of Health what's called an outbreak number, which is the number that acknowledges that you have an outbreak and allows us to keep track of you, and a point of contact at the local health department, who should have a corresponding point of contact at the state health department. And so when you report to the local and state health departments and within 24 hours you haven't got an outbreak number and you don't have a point of contact with whom you're communicating at the local health department, that means your report may not have been received properly. And so it's worth following up on again, because having that outbreak number and having that point of contact is key, because that's your first place to go for questions about testing, access to testing, sometimes access to personal protective equipment, recommendations, access to Goteams if you need to call in a National Guard support team or any kind of other staffing support. That local health department contact really should be your first point of contact in terms of support for these outbreaks. And so making sure you know who your point of contact is at the local health department when you report immediately, you get that outbreak number and you're in regular correspondence with that person, is key. And we're going to work on trying to improve that process on our own end. One thing we're thinking about is typically we assign outbreaks based on homes, but we may expand that to assign outbreaks based on programs. So if there's an outbreak in a home, we may just automatically say, okay, we're going to start trying to serve the entire program. Okay, so second issue has been access to testing. And access to testing is an issue everywhere, but we're really hoping that improved addressing some of the communications issues in partnership with us and the local health department can expedite access to testing. And in particular, what we'd really like to make sure happens is that you have the capacity to test your residents if they become sick. In other words, not wait until your first case is diagnosed in the emergency department or in the hospital, and remove any incentive to have your patient sent to the emergency department or to the hospital for the purpose of getting a diagnosis, because many people in your programs may not be amenable or able to go to a drive-through testing center. So we want to try to avoid that, and we're working to try to address that concern. Another big challenge that's been raised is design of the homes, and recognizing that these are small group environments. They're set up like residential homes. They're not hospital-style settings or medical care-style settings. And so really thinking about how we can put together improved guidance specifically for you about how you can keep folks safe within those homes and do social distancing in those homes. And then also thinking about maybe strategies for when resources are available, when residents should be temporarily transferred out to a new location, and if so, how to do that safely and how to protect residents who remain. So all that's coming. Finally, I want to briefly talk about the issue of staffing. So staffing is the #1 challenge that everybody is facing who operates any kind of congregate living setting, I think, anywhere, because staff are A, getting sick and leaving work during outbreaks, B, unable or unwilling to work in an environment where COVID-19 is potentially spreading, C, having trouble getting access to personal protective equipment, which exacerbates all of those problems, and then D, just maybe struggling with all of the rapidly changing guidelines and also moving between programs, and so represent your primary concern in terms of keeping both your staff safe and your residents safe, because they're really the only ones who are going in and out of your programs. So I wish I had a good solution for staffing shortages. I don't, although I do think that one thing that's important to be aware of is that A, it's important to have an emergency staffing plan in terms of what you will do if there were large staff shortages in the event that it happens. And then B, have that close contact with your local health departments. You can be prepared to reach out for a bridge team or a support team from the National Guard in the event that you have a short-term staffing crisis and there might be nobody there to care for your residents, so that that doesn't happen, because those teams can come on very short notice and try to help plug holes if there's a situation where you're concerned about adequate care in the short term as you try to put your emergency staffing plan in place. So be in close contact, and then we can better prepare for what is and isn't possible in the eventuality something like that should happen. And finally, I just want to talk briefly about staff moving between homes. So one of the major challenges that programs have faced is outbreaks starting in a single home that have spread to other homes because of the model of having many small homes with staff working at multiple homes, sometimes across multiple programs. And we'll have more to say on this, but I'll just briefly say that this is, I think, a necessary component of your programs, and we understand that. Having said as much, the #1 thing you can do to keep a small outbreak is dedicate your staff as much as possible, so that a small number of staff serve a small group of residents for an extended period of time, rather than having staff moving from homes to homes. As much as possible as home staff can be dedicated to a particular home or a particular small group of homes, this minimizes the likelihood of spread from home to home. And the best time to do that is before you have an outbreak, to build that into your plans, to try to build that into your normal operation as much as is feasibly possible. Because once you, excuse me, I'm so sorry. Once you have an outbreak on your hands, you're always discovering an outbreak after it's already started. And so having that dedicated staffing model has protected you in advance from any spread that may have been happening before you knew an outbreak had actually started. And so we'll talk more about that on next Friday, but that's one recommendation. So I'll stop there and now see if there are any questions. about
So
these
I'm
points,
just going
or
to
about
say,
anything else we've talked about.
thank you, Dr. Fetter. I'm just going to let everybody know that next Friday, our update is going to be our Deputy Secretary, and then we're going to turn it to Dr. Fetter to present the actual process and playbook that he's talking about specific to people that we serve in community living. So I'm going to open up the question box and start reading questions in there specific to questions for Dr. Fetter. So I will open those up. Can you remind us if Goteams are only sites that have positive or recent cases of positive COVID-19 diagnosis? Just need to get an understanding on that.
It's a good question. I don't know. I don't know if anybody's tried to request a Goteam for a site that doesn't yet have a positive case, but that has a suspected case and is concerned and wants to respond preemptively. There's certainly nothing that should stop you from reaching out to your local health department and trying to put in a request. And I will follow up on that. I think it should be possible for a Goteam to respond to a suspected case. But really what we are trying to make sure is that the resources and communication and partnership are there with the local health department such that a Goteam won't be necessary before you have a single positive case. In other words, that those short-term needs can be met locally by your own staff and by the local health department. So the answer is possibly yes, but I don't know if somebody's tried to request one yet. And that's a decision that's made jointly between you and the local health department. And then the requests are reviewed by the National Guard.
So when we call our health department, they tell us that as long as we are reporting to DDA, we do not need to report to them. So I think that's something that we need to put in our communications in the actual playbook, right, Dr. Fetter?
Yes, so you do need to report to the local health department, and the local health departments need to know that you need to report to the local health department. So do report to the local health department, and it's incumbent on us to get the message out to the local health departments that you are required to report to them, and that if there is a confirmed case of COVID-19 in your program, that's an outbreak of COVID-19, and so we want it to be investigated just like any other outbreak. And I apologize if you haven't received guidance to that effect, either from us or from any of our partners. That's really incumbent on us at Communicable Disease to make sure that happens. I also just want to say in response to the previous question that my colleague Abigail, who is I think also on this webinar, just messaged me, and she has been working closely with Goteams, and she says, no, you don't need a positive case to request a Goteam. So that is a definitive answer to the question. You do not need a positive case to request a Goteam. Thank you.
Do you know, is there a distinction between a bridge strike and a Goteam, or are these terms being used interchangeably?
Good question. I think there's a distinction between Goteams and bridge teams, but the process for requesting always starts with the local health department. So from your perspective, it may be a distinction without difference. In general, the services that can be provided are 1, on-site infection control assessments, 2, access to testing if you need to test a large number of people in a relatively short period of time, and then 3, emergency staffing to stabilize a crisis. And then in addition, I think the bridge teams may be able to provide some short-term or medium-term staffing support. And there was just some new guidance that was put out about what those bridge teams can do. And so I will pass that Q&A along after the meeting, and hopefully that can be circulated so folks have a better idea of what those teams do. But I think the best way, because the resources we can provide are always changing, the best way to figure out what's possible is to work with your local health department to put in a request and describe what your needs are, and then see if those needs can be met. But in general, those are sort of the 3 groups of things: it's infection control assessments, assistance with testing, crisis and triage in the event a number of people are sick, and then emergency holdover staffing while you put an emergency staffing plan in place.
Okay. What if we get a staff member who reports to their employer their COVID-19 positive resulted 2 to 3 weeks later after their last contact with individuals, and other staff and during this time, none of the contacts in the programs do not show symptoms?
Sure. So that's a good question. In other words, basically like a former staff person, like somebody who tested positive but hasn't been in your program for weeks. So I think, to my mind, the key line would be 2 weeks. So if somebody hasn't been in any of your programs for 2 weeks, then they can't have spread COVID-19 in your program, and they can't have acquired COVID-19 in your program, because 2 weeks is how long it takes maximum, we think, from when you're exposed to COVID-19 and when you actually get sick. Anything within a 2-week period, I would probably proceed out of an abundance of caution and report it to the local health department, because then you're prepared in the event that somebody becomes sick and positive. And in theory, at any point during that 2-week period following the exposure to the staff person who's now positive, if they were either infectious then, or if somebody else in your program had COVID-19 but you didn't know it at the time, but they could now develop symptoms, or somebody else could develop symptoms, then you might catch it now. And so we could establish that partnership sooner. So no, if it's weeks ago and the person essentially has no affiliation with your program, then it's not an outbreak in your program. But I would say in general, if it's within 2 weeks, you would want to report it. The infectious period for COVID-19 is we consider to start 48 hours before a person first shows symptoms. So if somebody works in your program and then develops symptoms in the next 48 hours and tests positive, then that's absolutely an exposure, and you would assume that potentially anybody who worked with that person or anybody who was in a home where they worked and they worked with could have been exposed to COVID-19.
So I have lots of coming in. So and we talked about this, Dr. Fetter, in our conversations, and we have about 7, 8 providers here who say, as an agency, we have dedicated staff to our specific homes, and the problem is how many employees we have across multiple agencies, since most of these people have 2 or 3 jobs with different agencies. So we have them in our homes, specific to a home, but they may go work at another provider's home.
Right. So, okay. So first of all, better is always better. And I commend you tremendously for inconveniencing yourself to take those measures to try to dedicate your staff, because even if they are working across programs, you're still keeping your residents safer, and the residents in the other programs safer, and the staff and the residents in the other programs safer by continuing to do that. Having said as much, what we really want to try to improve is the process of quickly identifying all of the programs associated with a staff person who tests positive, to make sure that all programs are appropriately alerted in the event that a staff person tests positive or is exposed to COVID-19. And that's one of the process things that we need to work about. But I think essentially it involves, when one of your staff members tests positive, working with your local health department to communicate with that staff person, learn about all the other programs they may work for, and then make sure that information is reported to the local health department, and arguably more importantly, to DDA, because DDA will be a primary point of contact for every provider in the state. And so, DDA will be able to rapidly get in touch with any providers who may not know that they've had a positive staff person, but will. And of course, we would too, but DDA is has contact information on their providers. So I think while it's impossible for us to force employees to work for a single provider, nor do I think that that's appropriate or sustainable, the key thing is, in the event that somebody's working for multiple programs and is potentially exposed or test positive, we want other programs to know so that they can make decisions accordingly.
This one is, if an individual dies in the hospital, are we still responsible to report it to the local health department?
Yes, if somebody is a resident of your program, is transferred to the hospital and dies in the hospital, you absolutely have a responsibility to report that to the local health department. Just because that, for one reason, it's because it helps us be sure we're aware of the scope of the challenge throughout the state of adults and persons with disabilities who have passed away from COVID-19. In other words, we're notified of deaths in the hospital, but we don't know that that person is developmentally disabled. We want to know that so that we can understand the full scope of the problem. making guidelines and informing the decisions we make. So yes, it is essential that you report that, and it is to the benefit of your residents and programs and everybody else.
Some of our staff have gotten positive a day after working with us, but never reported until 2 to 3 weeks later. Do we have to report it to the health department even when no one is showing symptoms after 3 weeks of contact?
So first of all, I think there's a couple of things there. So the first is that anybody who tests positive for COVID-19 is required generally, not just working for a program with people with developmental disabilities, but like as a rule in the state of Maryland, must stay home until 10 days after their positive test result. And in addition, 72 hours after their symptoms have resolved. So any staff person who tested positive should have been obligated to call sick, out of work sick. They have a right to medical privacy, but they should have been obligated to call out sick generally and say, I'm sick and I will need to take off for this amount of time. In terms of reporting, yes, it should still be reported to the state for a couple of reasons. One, for completeness, because we want to know whenever a provider in a DDA program develops COVID-19, because it helps us understand the level of risk that exists in your programs and helps us make decisions and allocate resources. Two, because we may be able to help you, because then the local health department can be in correspondence with you and may help you detect something you may have missed, for example, symptoms in a resident that may not have previously noted. And three, because of the reason we already discussed, which is that person may work for multiple programs. So if he's reported to the local health department, even if it's 3 weeks late, now we know he's a DDA provider, they can potentially do an investigation and identify another program where people may be sick, which obviously we would want to know right away. Are there any more questions?
There are several that are very specific to the local health department and the communication and lack of. So I'm going to read you one that captures all of them, I think. There appears to be a disparity between the county and the city health departments, testing availability, reporting, requirements, level of support. What is the department doing about this? This is why Dr. Fetter started the way that he did, what his observations have been, and why he talked about what we're going to do and what we're going to share with local health departments. So Dr. Fetter, do you want to expand on that?
Sure. I mean, what I can say is that, we work extremely closely with our partners in the county health department. And this is a Herculean effort for them, just like it is for you. And there are resource differences across counties. Counties have different needs and different programs, different abilities, and may make different prioritization choices with the limited resources that are provided to them. And so there are limits on what we can do, but what we can do is clarify expectations and standards and process so that I can't say that, for example, testing availability will be the same in every county because different counties will have access to different resources and different abilities to make testing available. For example, if a county has a large affluent hospital system that's able to supplement their testing capacity significantly, that greatly changes what they're able to do in terms of providing testing rapidly to a larger number of people who may be exposed but not symptomatic. And that's not something that, unfortunately, if we could have that everywhere, obviously we would. But having said as much, it's incumbent on us, I think, to really make expectations clear and make guidance clear so that your needs are being met as consistently as possible. And to the extent that there are differences, it's only because of differences in resources and not differences in terms of practices, which should be standardized. And if you have concerns and you're having trouble communicating, remember, there always should be a point of contact at the State Health Department, and there's also DDA. And so taking advantage of all of those resources can help make sure that somebody is alerted and follows up with you or is able to give you a clear answer about why something is or is not possible.
Yeah, there's about 3 or 4 now that come up and say that they've gone and requested a Goteam at their local health departments, but they said they could not do anything because the person was not experiencing symptoms. And then another one has said that they had gone to the local health department yesterday to request a Goteam, and they were told that the Goteams were not up yet and running. And so they're just getting different things. And this is a provider from Howard County. This other provider is from Baltimore County, and this other provider is from PG County. So I kind of know the names of the people in here, so I can tell you where they're from. And so there's just, I'm trying to read because they're all kind of the same. So I'm just reading some of the specific things, and they're mainly about what's happening when they're going to the local health department and what they're being told.
I think, so I hear you, I think that makes sense. And I think in terms of Goteam requests specifically, I mean, I don't know exactly the basis on which those are prioritized. I mean, I do think that while you can always submit a request, that homes that have a positive case that has been or was in the home will be prioritized. And what I don't think the Goteams can do is just, if there are staff shortages generally because of concerns about COVID-19, but nobody has been sick, I don't think that Goteams can sort of preemptively come and stabilize things in preparation for hypothetical COVID-19 outbreak. They're there to respond to suspected outbreaks, meaning somebody in your home is sick and could have COVID-19, or confirmed outbreaks, meaning somebody who is in your home or works in your home did have COVID-19, even if they're now in the emergency department or in the hospital. And in terms of other communication issues with local health departments, again, I think it really all comes back to making sure that you have a dedicated point of contact, you're assigned an outbreak number, there's a corresponding point of contact at the state health department, which might be me, which might be one of my colleagues. And so we're able to make sure that these issues are addressed consistently. And I hear you 100%, and we are working on addressing these concerns through improved communication with local health departments. So I hear
okay. You. And there's one here, and it's actually asked several times, is how do we report to the local health department or CDC if we do not have staff consents to release their information?
So, okay, so that's a fair question. So the local health department is, so you're obligated to report, and the local health department already knows the name of the person who's tested positive, because all COVID-19 is a reportable disease in Maryland. So any positive lab report for COVID-19 is sent to the state health department and then in turn to local health departments automatically. So they already know that person has tested positive for COVID-19. What they don't, or they should already know, because the healthcare provider who tested them is obligated to report it legally, and that's within HIPAA. That's how reportable diseases work. So your role is to notify them just that that person is a staff person in a group home for adults with disabilities, and so you are not violating your staffers' privacy by reporting they've tested positive for COVID-19, because we already know they've tested positive for COVID-19. We just don't know that they work in a group home. And so we need to know that so that we're able to support your program. And in general, you should be, when you're communicating with local health departments, I'm sure many of you have seen line lists of residents and staff who are in your program who have tested positive or have symptoms or tested negative to date. We're going to provide more clarification about doing those line lists, but they are A, obligatory, and B, permissible. You don't need consents because the local health department already should know the test results. We just want to associate the test results with your program.
Do you know if once a person has had COVID-19, can they get it again?
I wish I did. If I did, this would make all of our lives a lot easier. I think the short answer is no. I don't know. The science is not there, so I can't give you a definitive answer. The medium-length answer is that,
can they get it again? Somebody, can you mute your line, please, if you're on? If you came back on, there's a delay. So I don't know. Thank you.
So the short answer is I don't know. I think based on what we know today and what we know about other infectious diseases and what we know about other coronaviruses like SARS and MERS, we think that probably when you get it, most people have some immunity for some time. In other words, most people who get it won't get it again for some time. But we don't know how long that lasts, and we don't know if there are exceptions to that. And we don't think that immunity is going to last forever, certainly necessarily. Whether it lasts days or months or years, those are maybe the most important question. And unfortunately, because this is a new disease, it could take days or months or years to answer them, because we won't know until we start seeing definitive evidence that people have actually contracted a second COVID-19 infection. And I know many of you have probably read reports in the media about people being reinfected with COVID-19. Many of those reports have subsequently, there's been evidence to the contrary that suggests that in fact, those were not people who were infected twice with separate infections, but instead had the same infection that sort of was there, and then the symptoms went away, and maybe they had a negative test, but there was still a little bit of virus RNA left in their respiratory tract, and so they tested positive again later. In other words, it was actually the same virus, it wasn't a new infection. There's been no conclusive evidence, so far as I know, of people who have actually been infected with this virus twice, with two viruses that are clearly distinct, which we would know from genetic evidence.
So I've gotten about 5 questions, and they're all very similar. And I don't have the answer to, but I think that we need to bring it up here with everybody. Maybe have our attorneys involved here, only just because it says that that everybody needs to, the COVID-19 positive needs to be reported to the health department. The problem with our providers that they're saying is that while this is true, how do they report then in DDA's reporting or their agency reporting to another person about somebody's health condition, and when that violate HIPAA requirements? Because you're relating a health condition to another person outside that they have not given you permission. So how we would address that?
Sorry,
and this is specifically with providers who are sharing staff. So the question here is that, as you stated,
another provider. So if you learn that your staff person is working for another program. Oh,
yeah. Or even if DDA gets to that.
Right. So you would notify the local health department or the DDA that that staff person works for multiple programs, and then it would be the responsibility of the health department to figure out how to do that. And so the staff person should be notifying their own program, and typically they would. But it's not. In other words, if a staff person isn't notifying, like you find out your staff person is tested positive, and you know they work for another program, you can't and you shouldn't, and you have no obligation to tell that other program that staff person tested positive. Tell the health department. It's our job to notify that program that there's been an exposure. And if there's concerns about privacy, and this person doesn't want to notify them or isn't going to notify them, we would do it anonymously. So we would say somebody who has been in your program has exposed that program to COVID-19, and so we're opening an outbreak, and we should start taking these measures to prevent it. So that would be our responsibility to notify the other programs, not you. We're just asking you to help us identify situations where that may be the case.
Okay, I'm looking to see if there's any more specific questions related to providers and COVID and being tested positive. Do you need to be tested again once you are positive to make sure that you are no longer positive?
No, that's a good question. The answer is you should wait. You should wait until. So let's say I'm going to prevent two kinds of situations. The first is a person who tests positive and is sick, has symptoms of COVID-19. This is most people who test positive are actually sick. Okay, those people need to wait 10 days since their symptoms first started. 10 days since their symptoms first started, and then 72 hours after their symptoms ended. So in other words, if your symptoms went away within 10 days, then 10 days is enough. But if you're still sick after 10 days, you've got to wait 72 hours until you are A, without a fever for 72 hours, without using any fever reducing medications, and B, your other symptoms are mostly better. Once you've reached that point where you're 10 days past the onset of your illness, your fever's been gone for 72 hours, and your symptoms are mostly better, you can go back to work. And if you're a resident, you can resume normal activities. You don't have to be isolated or move to a separate isolation program or anything like that. That's recovery. Now, there's another option, which is to retest people. So you can retest people, but people have false negative tests. And so to clear somebody sooner than that, we would require you to have 2 negative tests collected 24 hours apart, which is typically not feasible because of testing shortages. And also, we don't really have any preference for that anyway, because it turns, one thing that I think is sometimes can be confusing is that people can have virus RNA in their respiratory tract, which is what we actually test for, but not actually be able to spread COVID-19 anymore because they don't have any virus that can grow in their respiratory tract. And so the 10 days minimum guidance is based on, right now, the longest times that we've seen people are still able to actually infect others with COVID-19. And so we know people are often more comfortable with the test-based retesting guidance. You can do that, but that testing isn't widely available. We encourage you to use that symptom-based guidance. And then the final question that often comes up is, what do we do if somebody tests positive, but they never show any symptoms? So the answer is that person needs to wait 10 days from the date their test specimen got collected. Okay? So they wait 10 days from the date their test specimen got collected. If they still haven't shown any symptoms after 10 days after the day they got collected, they're good to go.
Great, thank you so much. This one is about the health department takes too long to notify a program and they need to know as soon as possible. And some providers have been notifying each other of positive staff, and relying info through the Department of Health may cause a delay that is potentially dangerous. So they're very concerned, and so they just wanted to know what other things can they do.
So first, I think it's incumbent on us to expedite that process. Second of all, I'm sorry, it is incumbent on us to expedite that process, full stop. Having said as much, if your staff person consents to notifying those other programs, they can do so. You can do so on their behalf if they consent to that. Yeah.
Okay. For DDA's perspective, we will be reviewing the playbook that we're going to be working together and making sure that we address some of these questions. I am going to populate all the questions related to COVID-19 positive and the issues that you've shared with us in your residential sites. And then I'll be sharing this with Dr. Fetter so that we can make sure we address this in the playbook. And then I'm going to read 2 more questions, and then we are going to end our webinar. So, so this one is going to say, when we start back towards full operations, can we require tests for the people we serve that have been pulled by their family members? If so, where and how do we get to ensure that the people that we support are coming back that are not positive?
That's a great question, and I think the question about what you can and can't require is better answered by somebody from DDA in terms of me than I can. So I apologize. I can't answer what you can require or not. But in terms
Dr.
of
Fetter, we put together that there's a list that we share with our providers about people coming back, like from the hospital, or people coming back from the visits that we share with you. Maybe we can add that into the toolkit, because it would be the same thing that they're outside of the home. What do you need to know when they come back to the home?
I'm sorry. Okay, yes. Okay, so I thought you were talking about resuming normal operations, like people who are currently not a part of your home, for example, because they're homes with family or something like that, coming back. So
Right.
Somebody goes to the hospital and they come back to your home. The recommendation is that that person do, well, there's two possibilities, okay? One is that the person could have been, well, there's really three possibilities. Let me talk this through actually, because this is important to think through. And we're going to put it, yes, we will definitely provide more detailed written guidance about how to handle this situation. But basically, there's three possibilities. One is the person goes to the hospital for COVID-19 and then recovers from COVID-19 in the hospital. So if they're recovered, they're recovered. They can come back to your program. They won't infect other people. You know, they should resume normal life. And the hospital may determine that based on tests, or they may determine it based on symptoms. But if the hospital says your resident is recovered, we think they're recovered. The second possibility is that you have a resident who's discharged from the hospital because they are healthy enough to leave the hospital, but they are still sick with COVID-19. They're still having some symptoms. They're still testing positive. In that case, that person would immediately need to go into isolation, and you would follow whatever your isolation plan is for having somebody with COVID-19 in your program, whether that's having a special room for them and making sure they stay in that room, or having a special separate residence for people who have COVID-19. Whatever your plan is, you would immediately want that person in isolation. The third question is, what happens if somebody goes to the hospital or leaves the program or for some other kind of medical care, but doesn't have COVID-19, but then they come back, and you want to know what to do since they've been in a healthcare setting and potentially could have contracted COVID-19. And the answer then is we typically recommend a 14-day quarantine period. In other words, put that person on precautions, use full personal protective equipment when working with that person, try to ask them to stay in the home or stay in their room as much as possible during that 14-day period when they've returned from their last exposure to healthcare, because there was some risk for contracting COVID-19 while they were in healthcare. As far as what to do when folks come back from their homes to the program, that I think is more complicated, because we can't necessarily, the risk of exposure there is lower. So I don't know, we would recommend quarantining all those folks, but maybe we would. And also, we can't guarantee access to testing in the community. If we could, we would. And so to the extent that we can figure out how to expand access for your programs, that's something we're going to work on. But I never like to promise something that we can't provide, so I have to be upfront about that.
Thank you, Dr. Fetter. Really appreciate it. We're going a little over time. The last one is really not a question, it's a statement. I don't really read statements out loud, but because it's Friday, I'm going to read this one. And this one's from a family in microboards. And it says, I just want to thank the DDA for the webinars. They are extremely helpful. Dr. Fetter has been great. Just want to thank all involved in presenting, pulling this together. Never ever have I been as impressed and appreciate the sharing information from the DDA, and the state officials have been clear and addressed in real time. Thank you all. For special thanks to Bernie, also Donna, who's helped with putting all this together in a great style. Thank you. So thank you all. Please be safe. And thank you for joining us, and we'll have Dr. Fetter next Friday. Have a wonderful weekend.